Once again, uPempempe buye phethe inhliziyo this time. Head to toe with Dr. Tebelele, channel 260, Mpuma Kapa TV, your favorite DSTV channel. 9 p.m. is the hour. At 21 hours if almost 9 p.m. Namhlanje siphethe ingcaphephe yenhliziyo zabantwana. Dr. Samkelo Jiyana, inzalelwane yaseQonce. Engaphelelanga nje ufunda eQonce, got MPCHB at WSU. University yamkeleyo ngapha eMthatha, waphuma apho wasebenza East London Hospital Complex, iKulta, iCecilia Makiwane, iFree Hospital, neRed Cross apho fumene khona uba ingcaphephe yabantwana, pediatric cardiologist. Why member of the, why fellow of the College of Pediatricians. But he was never satisfied with that. He was too academic. He went on to do certificate in pediatric cardiology. That is why he's carrying a heart for us. Sam, can you kindly greet our viewers? And thank you for honoring us.
Yeah. Good evening to the viewers and good evening to everyone listening today. Thank you for having me on the show.
Thank you, Sam. You've been in PE for quite some time.
Yeah.
I hear you trained under the late Prof. Pepeta.
Yes.
Dr. Ngele and Adele Grayling.
Yes.
How is PE?
PE is always wonderful, very welcoming, always a good sense of community. And I must say, now that I'm in private, I really enjoy the support. I really do.
Thank you so much. Are you getting a lot of support from our GPs?
Yeah, I am getting a support from the
you
GPs.
Must educate us, Miss. The heart is too tiny and we may miss some of these things. So that is why we brought you in to create nice lessons and simple lessons for the community and also for people who are not doing the heart on a daily basis. Yeah. You've got a practice at Knekker's Hospital and also you're doing some sessional work for the state.
Yes, I am.
You must never be lost to the state.
No,
a lot
definitely.
of these problems happen at the state.
No, definitely.
Thank you so much for your service. Today we're talking tetralogy. You call it TOF. What is TOF?
Okay. You know how medicine always engages the Latin language. So tetralogy means that there's 4 problems. Tetralogy of
Tetra means 4.
Yes. So Fellow was the doctor who first described it. So firstly, this is what a heart looks like. Obviously, a child's heart is going to be much smaller, but this is what a heart looks like. You have the right atrium, right ventricle, left atrium. So blood enters and comes in deoxygenated from the right side. It comes from the IVC, from this blue part, blue blood vessel coming from the top of the head and the chest, draining that, and from the bottom of the body, from the IVC, goes to the right ventricle. Let me just open that. Goes to the right ventricle, and then is carried to the pulmonary arteries. Must put the heart together so that you can have a mental picture. So carried to the pulmonary arteries and comes back deoxygenated to the left side of the heart, and via the pulmonary arteries at the back goes to the left atrium, left ventricle, and is carried to the aorta and to the head and to the rest of the body carrying oxygen. So in these children, they may be born with these 4 problems. Firstly, it starts with the obstruction of the right ventricular outflow tract or the pulmonary artery. So it may be anywhere here. So it may be at the level of the valve, it may be below where you've got infundibular muscles, or it may be above the valve. And then you've got, because of this obstruction, the right ventricle becomes thicker. And we speak about right ventricular hypertrophy. Okay. And then there's a hole between the 2 sides, which is the ventricular septal defect, the third thing. And then number 4, the aorta, instead of sticking strictly to the left side of the heart, is overriding, is sort of committed between the left and the right. Okay. So that becomes the fourth problem. That's when we speak about tetralogy
So it
of
becomes
Fallot.
4 problems that actually make up this TOF. Thank you so
Yes.
much.
Yeah.
That becomes clearer.
Yeah.
And
So a child may be diagnosed with tetralogy of Fallot because of the hole in the chest, which makes a noise, which your GP or your doctor will describe as having a heart murmur. So the doctor may pick up a heart murmur or may notice that the child is blue. But this does not mean that it cannot be missed, because initially within the first 6 weeks, the pressure is higher on the right side compared to the left side. It's only after 6 weeks does the pressure in the lungs come down. Then the pressure becomes higher on the left side than the right side, producing that sound that you hear. So that's how it may be missed. So that's why it's important that when a child is born, the mother takes the child routinely for their immunizations and also for their checks. Because even if it was missed at birth, if the child goes for a baby check with the immunizations, the sister will definitely, or the doctor will pick it up. So how will this child present if it's a newborn?
so Dr. Jiyana, so you said this may not happen immediately after birth. The child may be able to be born without anyone noticing, but as time progresses, then it gets noticed.
It gets noticed. Yeah, not only that, so some children may not be even noticed in the newborn period, which is very common in our South African setting. I think initially because there was less knowledge that children could even have heart conditions, but also just lack of awareness. And as I said in the previous show, that people will see their child is blue and think, I went to fuze kokwabo kanye ngutata kunjeni. But in this time where the child's mouth is blue, it's because there's not enough oxygen going to the body, or that the child is clubbed and has fingers that look like that have got curved nails, and someone will not recognize that there is something wrong, which the clinician or the nurse or the doctor will pick up. If that's even not picked up and the child grows on, you'll find that the child goes and plays, but most of the time, once they are tired, they don't just sit down, but they crouch and they kneel, as if they're sitting on top of the bathroom seat, or and they do that, what we call as spelling. So during that time, that child, when the child is spelling, they're increasing the amount of blood coming back from the lungs by causing pressure and kneeling down.
Unknowingly.
So unknowingly. So
before you take us further on the symptoms, I'm enjoying this. Sam. It's like I'm back at school.
Yes.
We're gonna take a little break,
Yes.
and then we'll be back, and then we'll take us further on the symptoms, and then we're also gonna look into risk factors. Is there anything that parents do maybe during the making of the baby that actually lead to some of those things? You're gonna guide us, and then we're gonna look into how to diagnose this thing at your level now.
Okay.
Thank you so much. Never leave your screens. We'll be back shortly after taking drinks. 9 p.m. Thank you. Welcome back. We're speaking TOF, Tetralogy of Fallot. Ucho Dr. Samkelo Jiyana, our pediatric cardiologist, who is with us in the house with a big but small heart. Thank you, Sam.
Thank you. So as we were saying, the older children with tetralogy of Fallot may present themselves. The mother might notice that this child gets tired, but when the child gets tired, they crouch and kneel, normally to overcome that obstruction that's being caused by this either above the pulmonary valve or below the pulmonary valve. So those are the symptoms that they may present with. Of course, again, they may be failing to thrive or not growing.
Okay.
If they look at the clinic card or they look at their growth chart, they'll find that this child is not growing according to what it's supposed to be growing at. So those are the things that the parents can use to find and confirm if they've got. Also, family history is important, as we were asking, as we said before in this previous portion. It's important if there is a history of congenital heart disease, the most you need to screen the children as well. And within the siblings, especially with Tetralogy of Fallot, if one sibling has Tetralogy of Fallot, then it increases 25% chance that the next sibling will also have Tetralogy of Fallot.
Okay.
Yeah. So
there's a genetic component
there
to
is
it.
a genetic component to it.
Is it something that you guys can pick before a child is born?
You can diagnose it if the mother has a fetal scan during pregnancy, especially in high-risk pregnancies. That is where the mother's advanced maternal age, that's an older kind of mother, or previous miscarriages, or previous stillborns. Then the mother then would have to have a scan to also look at the baby's well-being.
That's good.
Yeah.
There's a lot that goes into this.
Yeah.
Diagnosis?
So
The child has been picked up by the mother or by the GP or by the clinic. Now is at your level as a pediatric cardiologist. What do you
so
get to
for
do?
us, it's a clinical examination, and then it also includes the X-ray, where we will see the cardiologist will tell you, this child has got a boot-shaped heart. That is because in the X-ray, normally this blood vessel will take up that portion, but it will create a cavity or make the impression of a boot. Because of that, there isn't this blood vessel. It will be normally thinner than normal or smaller than normal. And also because this right ventricle is now bigger, it's hypertrophied than what it's supposed to be, it then, because it's sitting in the front and the left is more at the back, it then pushes up the heart to look like a boot. Okay, so that's what we will see on the X-ray. And then we will do an echocardiogram. That's where we do an ultrasound of the heart. We put a probe on the heart and we see and we look for those abnormalities, those 4 abnormalities which the viewers might want to remind themselves of. That is the pulmonary stenosis, the hypertrophy of the right ventricle, the overriding aorta. So this blood vessel is not committed to the left side of the heart, but committed between the two blood vessels. So those are the things that we will see on the echocardiogram. Once we've seen that and confirmed that, we then may go to cath lab and have a look inside cardiac in the cath lab to see how big are these pulmonary arteries. Are they big enough for the surgeon to do an immediate repair? That is to put a patch where there's a hole there and then open up this right ventricular outflow tract and open up this valve that's narrow? Or does it mean that the surgeon needs to put a shunt to actually make these pulmonary arteries grow bigger a bit? Okay. We can also, in cath lab, in the meantime, say you are in an area which does not have a surgeon. For example, there is a lack of cardiothoracic surgeons. Even in PE, there's just only one, and he's servicing the whole province, not just Port Elizabeth.
Only one? Only one.
So if, for example, the cardiologist in Mthatha has got a patient who's got critical obstruction here, he may go into cath lab and put a stent and open up this blood vessel that's open, that's obstructed, until such time that the surgery can be done, saving the child's life in the meantime.
Okay.
Yeah.
So they can delay the operation.
We can delay. Yeah.
Does it last long?
The stent, it does last. It can last for a good 1 to 3 years until the operation is done. But I don't think the child would wait that long, because especially if they needed a stent, it would be something that would be done soon thereafterwards. The operation may be done with an experienced surgeon. people think that when they hear operation, you will see in the video that will pay in the end, that a child does survive when it's had a heart operation. Because when you hear heart operation, you think, the child is not going to survive, it's not going to make it, it's a risky thing. But most of the time, the surgeon will close the hole, open this valve, and then the child will be fine thereafter. It may spend 1 to 2 weeks in ICU, and thereafter the child becomes normal again. Of course, there will never be as if that they don't need to do anything. They'll always have to follow up at the hospital with us, at least in the first month after the operation, 3rd month, and thereafter 6 months, and then after that, yearly after the operation. So it will not be a regular thing.
As someone who's involved in some research and some studies, looking at a child who has had all this tough, how do they become in terms of, do they catch up with the other kids? Let's say they were failing to thrive in terms of activity, exercise, they were less on that. How do they fare after operation?
They do fare well if the lesion is picked up earlier. But remember, blood always takes a point of least resistance. So if there's an obstruction to the pulmonary artery, the blood is not gonna go to that area. So the child is gonna get deoxygenated blood, but this child is growing. So if the child has got predominantly deoxygenated blood, then the brain is also not going to develop as well. Then there may be some neurodevelopmental issues. But if the lesion is picked up early, then the child does well, like any other child. But even what we've noticed in our area, because of I think our patients are more resilient. Even if you've done a Tetralogy of Fallot later on, not that they become mentally disabled or have they are not capable like any other child.
We're going to look into some of these myths when we come out of the drinks break. We're going to take a short break. Stick to your screen. Don't go away. We'll be back shortly. Welcome back to Head to Toe with Dr. Tebelele at Mpumakapa TV, channel 260, 9 p.m. We're talking and looking at the heart of the baby. Sijonga inhliziyo yomntana. Inhliziyo yomntana ene conditions ezine ekuthiwa xa zibizwa Tetralogy of Fallot. Okanye xa beyikhumsha kababizi lathi wogqibela Tetralogy of Fallot. The conditions eziyi-4 but all in one. Sithetha nengcaphephe yethu uDr Samkelo Jiyana, a fellow of the College of Pediatric Cardiologists in South Africa. Sam, thank you so much for being with us. And now we're going to look into the myths. You say a lot of parents tend to delay or be reluctant in taking some of these kids to centers like cardiologist clinics or to doctors and clinics.
Yes.
Is there anything that you guys are doing to educate parents?
We are educating them. We are promoting, there's actually more fellows being trained within the speciality itself. And not only that, from having one pediatric cardiologist, for example, in PE, we've now, when the late Professor Peter started, he has now graduated 5 people from underneath him. We are conducting regular information sessions, for example, on radio, and our raising awareness with different foundations that we've started to help children get surgery and those who cannot access surgery.
I see there's a foundation that you are working with. It's called Thanda Heart Foundation. Where is it based?
So it's based here in Port Elizabeth, and we are mainly using that foundation as a vehicle to help all the children who are not being able to access cardiac surgery within the Eastern Cape. Because we only have one surgeon, so who can only do so much. And at the most, when we're doing cardiac surgery in Port Elizabeth, we're doing 2 surgeries a week.
Okay.
At least if we are doing proper, providing a proper surgeries, at least we should be able to have at least four children operated on a week. But because of this delay, where we are currently now doing one child a week, because of the way things have changed, staffing, and everything else. So through the foundation, we're trying to, the children are not stopping being diagnosed with the conditions. They're not stopping coming because there's not enough surgical capacity. So we're trying to create a chance for them to be operated on elsewhere within other provinces, using the funds from the Tender Heart Foundation in the private sector, where the foundation will pay for them to be operated on in the private sector and will pay for their hospital stay in the private sector. Currently, we're working with 2 hospitals, Busamed in Modderfontein and another hospital in Cape Town. So we're using those hospitals to try and combat this. But the foundation is mainly the main vehicle behind it, and then we've got the partners that we are bringing in to support this this initiative.
That's a very good initiative. Is it reaching people in rural areas?
We are using. We're still in the initiation phase of it, because it's supposed to. We are working with all the doctors, the cardiologist in Umtata, people in East London, people in PE, all the patients that are being referred to us. We are hoping that those who cannot access surgery immediately and need surgery immediately then can be referred for surgery elsewhere. So whether you come from Banduli or you come from Queenstown, you get the same chance of getting a surgery.
That's a wonderful job. Yeah. Any links to Nelson Mandela Academy Children's Hospital?
It's linked with Nelson Mandela Children's Hospital. So the team that is taking care of the children will be based at Nelson Mandela Children's Hospital. So even if there's no ICU capacity, but the same cardiologists who are in Nelson Mandela Children's Hospital will take care of the children wherever they are.
Is there a point in changing wives? Maybe you give birth to a child with a TOF.
No.
Getting a new wife, do you stand a chance that you may give?
No. And you find that especially, even with the Down syndrome children, you'll find that the father says, this child does not look like anyone in this family. And it has nothing.
They start
the one who's a yeah. And it has nothing to do with that.
Yeah, we've got a lot of work to do. That's why I'm raising it. A lot of people are misinformed. These are the myths and stereotypes that are occupying a lot of people. Hence, we are grateful to have so many pediatric cardiologists in our province, and it means the services are going to reach so many. I didn't know that the heart was that common.
Yeah, it is.
Yeah, especially the blue baby thing and the tough issues. I thought they were complicated issues that you rarely find. So thank you for enlightening us.
No.
You mentioned the role of alcohol and tobacco. Does tobacco have any role in terms of risk factors?
Tobacco has got some role as well, especially in the development of the child. So a child may have heart conditions associated with the mother smoking and the mother drinking, but especially more with the drinking, more than the smoking. With the smoking, it affects the whole body development.
In terms of a pregnant mother, is there anything that we eat or they eat that may actually increase risk of having a TOF?
No, not really. No.
Not really. No. Okay, that's good. And then to the viewers, what kind of just looking now at the blue baby syndrome together with the TOF, what the wrap-up words, the lessons that would like them to grasp from you? Because you are a very busy man, very difficult to find. Last message to the viewers.
Firstly, my message would be congenital heart disease, and that is children born with heart conditions. They are common, but we can treat them, and there is help out there. And you do not need to be afraid of getting help for your child. And even if your child has been diagnosed with a heart condition, doesn't mean that there's a death sentence. A lot can be done. We have gone from being able to do nothing for congenital heart disease from maybe 30 years ago to now there's very little that cannot be saved. And actually, because of that, I'm dealing with grown-up congenital heart disease, because these children now, they had congenital heart disease as children, but now they are grown up.
Thank you so much, Dr. Sam Jiyana. That's our pediatric cardiologist. You've heard it all. We spoke of TOF, from the blue baby syndrome. We think you are now equipped. Never forget to follow us on Facebook, Aphile Communications, YouTube, Aphile Communications, and meet us every Thursday at 9 p.m. Go head to toe with Dr. T. Channel 260, that's your DSTV. Thank you so much.